right, I think we have everyone that we're expecting today. I recommend we get started, Lou.
All right. This meeting is called to order. Good morning and welcome. Due to COVID-19 and the Governor's Proclamation 2028, we're meeting today via Zoom only, which we're going to do until further notice. We're going to do roll call to identify the board members that are with us today, starting with Terry.
Good morning.
Good morning. Allison.
Good morning.
Morning, Allison. Pam. Pam, are you with us?
Yes, I am. I'm sorry.
Oh, Pam. Pam. Oh. I see her, but it looks frozen. Oh, no, I see her moving. Can you hear us, Pam?
I don't think Pam can hear us.
I don't think she can either. Dave, why don't you have someone shoot her a text and we'll go from there. Dan has already chimed in. Amy.
Good morning.
Good morning. Donna.
Good morning.
Good morning. And Katie Hatfield from the AG's office.
Hello, everybody. Good morning.
Hello there. And I'm Lou McDermott. I'm the chair of the SEB board and the deputy HCA. With both board members and presenters attending virtually, it's helpful for the board to hold their questions until each presenter is done, or when the presenter pauses and asks if there are any questions. Board members will also be watching you in case you use your Zoom hand to indicate that you have a question. The public will have an opportunity to provide general comments at the end of the meeting during the public comment period. Dave, can you give us an overview of today's agenda, please?
Sure. Good morning, Chair McDermott, members of the board. We have a relatively short meeting in the grand scheme of the history of this board. I think that's kind of a phenomenon that tends to happen in the early spring meetings. So enjoy while you can, because we'll have fuller half-day meetings as we go further into the season. Today, we're going to start off with a discussion both about policy bills and the budget in the legislative session that wraps up next week, just to give you an update on how things have gone in this recent short session. We do have an eligibility and enrollment policy resolution to present to the board. This is the first stage in the ultimate request for the board to take action. We'll introduce today, familiarize yourselves with the concept in the resolution, then take it out for stakeholder and then bring it back for action at the next meeting. Then we'll have a brief presentation about some, whenever there are transitions that happen at the beginning of a calendar year, that can impact members. We try to describe that in advance and then describe how things went during the actual cutover or transition of whatever it is that was changing. And there were some changes to some of the administrative aspects of the pharmacy benefit within the Uniform Medical Plan. So we're going to go over kind of the end results to bookend that conversation. And then we're going to begin our multi-meeting journey talking about dental benefit design. Very excited to kick that part off with the board. I know many of you are as well, and that's what we'll be doing today.
Excellent. Any questions from the board on today's agenda? All righty. First item is Dave going to give us a follow-up from the January retreat.
Yes. There was one question that came up at the January retreat, and I thought that I would be able to address it just in this brief follow-up piece. I'm going to do a quick dive into it, but I think it's going to be more amenable to a presentation later this season. The question was really about pediatric vision benefits and how they compare to the PEB program. And it turns out that there's a lot of little nuances. At a macro level, the benefits have the same effect, but there are lots of details that are differences. So for example, both of them cover annual eye exams for children, but there are a few plans in PEB where there might be a copay. Or both of them cover frames in a 2-year increment, but in SEB it reboots January 1st of every year, and in PEB it's a rolling personal 24-month average. So it's 2 years, but the calculation is a little different. Or lenses are free in both of them, but some of the enhancements vary. So there's a lot of little details, and since we are going to need to have a vision benefit conversation later this board season anyway, I wanted to give a brief comment about how they functionally are the same and they have the same end results, but there are a lot of little details, and we'll bring a presentation back to the board later this season on that. That's the only question I had marked for follow-up, and I do want to acknowledge, because I like to do this as well, that the image that the Healthcare Authority will be using in this meeting is Mount Rainier, snow-covered Mount Rainier, as we hopefully are ending the winter season. So that's all I have as the rest of my opening remarks.
Awesome. And I just wanted to verify that, Pam, you've got audio now. You can hear us. A thumbs up. Excellent. Okay. Well, glad to have you all here. And let's jump into our agenda. The second item is the 2022 ledge season update. Kate Walker, Executive Special Assistant to the IRB Division, is going to provide an update on session, which is, by the way, almost over. Thank goodness. His materials are behind tab number 3. Kate, we can't hear you, buddy.
Coming through now?
Boom, gotcha.
Okay. All right. Good morning, Chair McDermott, members of the board. I'm happy to be here with you again to provide you an update on the 2022 legislative session. We, as Chair McDermott just mentioned, we are a week away from the end of session. Sign die is on the 10th, which is a week from today. So we have been engaged, continuing since our last meeting that we had with you all. The first meeting I think we had with you, or when I presented last, we had a very quick and rambunctious start to the session. I don't want to say it died down, but it certainly didn't maintain that pace throughout, which is much appreciated. It seems they had a lot of things kind of raring to go at the start of things. Start of session, and then as we moved into it, things kind of settled into the topical areas that they were going to be focusing on for the session. So we had maintained a nice even pace throughout, and our team has done a really fantastic job in getting analyses done, reviewing things timely, and providing important feedback to the legislators during this session. So as I like to do in each of these presentations, go over kind of the workload that our team has done so far. And this is a little outdated. This is as of more than about a week ago, and it hasn't changed too much in the last week or so. But our team has done a collective total of about 150 legislative analyses. Those are individual pieces of legislation that have been reviewed by our team. And you can see we did have quite a few high priorities that the ERB division was the lead analyst on for our agency. Which was a little bit of a change. A lot of things in the healthcare space and the insurance space that were proposed by the legislature this year. And so that's why we've had a higher number of the high priority and ERB-led bills that we have been analyzing this year as in comparison to the totals that we've had in the years past. So our team's done a really great job. I want to make sure I give them a good shout out for all the work they've done this session so far. Next slide, please. Here's our progression. Again, this is a little outdated. Things have been moving quite a bit. We've had 2 cutoffs since this slide was posted, or when I updated it. This is all of the ERB high lead bills that we are analyzing, tracking it through the whole process. The last cutoff that we had was on Monday. This was I think my date's wrong there. The fiscal chamber, oh, no, that's right. The opposite chamber is on the 4th, but the opposite chamber for fiscal was on Monday. We did see 4 bills progress through that. So we have a total of 5 pieces of legislation that are high priorities, that are lead that we are tracking through, including 1052, which did pass. So that's on the next slide. So it's noted, House Bill 1052, this is legislation that was introduced last year regarding performance guarantees. This did pass off the floor yesterday afternoon. So we're excited that after a multiple year journey to have this piece of clarifying legislation passed, that we were able to get it across the finish line. It's not that it was controversial at all. I think it was just so non-controversial or interesting that just kind of got oftentimes forgotten by and large. And there wasn't a negative vote on it the entire time of its process, but it did make it through off the Senate floor yesterday, and it has been signed by the Speaker of the House. So we expect to have that signed. That'll be nice to have that clarifying language included into the insurance code, which will assure that our use of performance guarantees in our contracting is in compliance with the insurance code. Dave, is there anything else you would want to add about 1052 that you think the board might be interested to know?
You cover it well. It's non-controversial. It just aligns historic practices and gets rid of any technical concerns of how the state does contracting. So
it's nice. It's a nice reassurance to have that done, but it's the effect of it is it will allow us to keep doing business as usual. So nice to have that done. It's not going to require us to change anything. That's a good piece of legislation for us, and that we can maintain our current operations with our contracts. The other legislations that, if I've struck them out on any of the following slides, it means that they didn't make it past a cutoff that they needed to do so. So we would consider it dead. And given that this is a short session, the legislation that has not made it through the cutoffs this session will be ended, and they'll have to be reintroduced next year, modified or reintroduced at a next session if they want that legislation to be considered again. So 1757, 55, 62, this was a legislation that would have allowed the non-represented ESD employees to participate in the PEB program as opposed to participate in the SEB program. This was legislation that we had assisted in drafting just at the request of the ESDs. If the legislature was going to pass that legislation, we wanted to make sure that it was drafted properly and would have the effect that they were going for. We weren't in support or against it. We were merely providing technical support, but neither of those bills did make it past cutoff, so they did not make it through this year in the session. However, there is one piece of legislation that I hadn't included on here that relates to, it's a piece of legislation that funds the represented employees at ESDs from the state. It's a very small piece of legislation, and it only impacts those employees and ESDs who are represented. And so that legislation is still moving. We don't have any indication that it doesn't have any significant impact other than additional funding to the 2 ESDs that currently have represented staff. If that's going to have a different effect in the future, we're not sure. We've not had any significant communications with the ESDs about the impact of that legislation, but we're keeping an eye out just to make sure, as it does have a very, very minor impact on our program, or as far as the entities that we serve from our program. We didn't see the passage of 1911 or 5700, which would have expanded the definition of a separated employee to include those who participate in Plan 2s. It was a novel idea. I think the first time we've seen it, but it did not make it. It made it pretty far in session, so we may see that pop up again in the future, and it would expand the eligibility of certain members, certain retirees for benefits a little earlier than they would otherwise have ability to enroll in. Next slide, please. Several of the RX pharmacy bills that didn't pass noted here, but 5610, the RX drug cost sharing did pass. In a nutshell, that legislation states that if there is a coupon, a manufacturer coupon for prescription drugs that is applied, the amount of that coupon is then applied to the member's deductible, and it's a very, very simplified version of it. But that did pass the House and the Senate, and so we'll wait to see the full impact of it, as the latest iteration of that had a striker introduced on the floor that was adopted, and we are just finalizing our analysis of that. That it was a fairly substantial change, so we're keeping an eye on that, but we do expect to see that get signed out of the legislature and over to the governor's office. The hearing instrument coverage bill, that did not make it through 1854, as neither did 5704 on the ARNP reimbursement rates. 1688 out-of-network charges, another kind of patient protection, consumer protection piece of legislation. It is still moving. I don't have it listed as having passed yet, but it is still active, and there's time for that to move through the process still, so we'll keep an eye on that. Next slide, please. Lastly, this should be 1689 biomarker testing. That is still moving as well. And 5702, which is the bill regarding donor breast milk coverage, that did pass the House yesterday. And so we'll continue to track that, and that has a lot of good positive impacts for members who need to have additional support for providing breast milk for their infants. With that, David, I also just want to turn to you. Are there any other pieces of legislation that you've tracked at all that you wanted to discuss? I tried to just hit the high points, but it's been a pretty quick session.
You covered things well. Thank you, Gabe.
All right, with that, I'd happy to take any questions. Otherwise, I think the next time we'll be doing a wrap up of the conclusion of session.
Hey, Dave, I'm seeing,
Yep.
Hang on a second. Oh, okay. I had lost the whole crew. All I could see was your room and Cade on my screen. And I was like, did we just lose everybody? But no, a setting must have got changed. I found it. Any questions from the board for Mr. Walker? All right, seeing none. Cade, thank you so much. Appreciate your time. Next agenda item is the 2022 supplemental budget update. Tanya Dool from our Financial Services Division is going to give us an update. Her materials behind tab number 4. Welcome, Tanya. Good to see you.
Thanks. Good morning, Chair McDermott, members of the board. For the record, my name is Tanya Dool. I'm the Urban Finance Manager, and I'm here to give an update on the supplemental budget. Next slide, please. First, we're going to talk through the proposed funding rates. Just as a quick reminder, funding rates are per eligible employee per month. The funding rates we're going to walk through are all adequate to maintain our current level of benefits, plus some additional funding that I will also discuss. And we do not have any concerns with any of the underlying assumptions within these funding rates. So on the next slide, I was here at the retreat and I briefed you on the governor's proposed funding rates, which are in the far left box in green. So the current school year funding rate of $968 will remain unchanged since we're in that current period. However, the next school year funding rate in the governor's proposed budget was reduced from $1,032 to $1,026. And what you'll see is the Senate and the House proposed budgets aligned with the governor's proposed budget at that $1,026. That reduction was utilizing some available surplus as well as funding some of our decision packages. Next slide. Again, like the funding rate, these are all similar between the governor's, the House, and the Senate proposed budgets. These remain the same from the board retreat that I discussed earlier in the year. So I'll just quickly walk through these, but ask if you have any questions. So all 3 versions of the proposed budgets included funding for FTEs for customer service staff, as well as an FTE within our portfolio management section. We also received the funding requested for our upcoming procurements that are needed. So we received $1.4 million in the SEBB program for some upcoming procurements. An example would be the administrator for our wellness benefit. Next, we received $350,000 within the SEBB program to complete a mental health parity analysis within the Uniform Medical Plan. And lastly, we received funding in all 3 versions of the budget for 5 FTEs to support our basic maintenance and operations of the SEBB My Account system. Dave, anything on any of those DPs you want to highlight?
Just that final one, the IT staff is a really critical one that we are keeping. All of the decision packages we put forward, we believe are urgent and important. That one more so than ever. I've said before that we need additional, we actually have no permanently funded maintenance and operations IT staff because of some historical reasons as to how the various program resources were established and kind of the timing of events that led to the creation of SEBB My Account. So having these FTEs should really help break some of the log jams that HCA and school districts are experiencing. Sometimes whenever a concern comes in from a school district, we have a lot of kind of IT resources that check the entire system to figure out if something is more isolated or comprehensive. Also enhancements to SEBB My Account. The staff would be able to the maintenance and operations staff would also be able to do some of the modifications So we hope to be able to break the logjam on some of those historic enhancement requests, as well as speed up some of the response time by having this more robust staff. So very excited to have these on. And this staff is funded as of July 1st. So a little bit longer, but there's light at the end of the tunnel on that piece. So very excited about that.
All right, thanks, Dave. So while all of those items were things that the governor's budget included, this last item here is something that is different between the most recent House version. This is a new proviso that was added. It includes $250,000 for the SEB program, as well as $250,000 for the PEP program, so a total of $500,000 for HCA to conduct a study of the Uniform Medical Plan Administration. So by the end of the biennium, HCA will submit a report that includes quite a few things. So the first being the administrative services that were provided prior to 2010, and those have that have been procured since, and what elements could be provided by HCA or through contracts. It also asks us to compare the administrative costs before and after the use of our current TPA contract, as well as assumptions on claims and existing performance guarantees, and also an implementation plan for HCA to resume the administration of either all or some of the administrative components at the end of the current TPA contract. Since this is new, Dave, is there anything else you want to add to what I just described?
Sure. So it is right now only in the House budget. Both of the chambers have passed their budgets off of their floors, so they'll be in conference, and differences like this is what get adjudicated in that conference process. So we'll see if it's ultimately in the final budget. I think the reason, there's a lot of reasons that this provision language could be coming up, but with the addition of SEB and the expansion of the amount of individuals who are in the Uniform Medical Plan, I think there's just a question as to evaluating the efficiency and use of either directly providing some services or continuing to contract out the services. Historically, before 2011, when the state began having a Regents as the third-party administrator, and then Regents was awarded the most recent contract that began in 2020. But before that, there was a lot more direct administration by the Healthcare Authority. There was a separate unit by the Healthcare Authority that was the Uniform Medical Plan, doing things like direct provider contract negotiations. That was something that the Healthcare Authority staff pre-2011 did. So there's just a question to look at the types of things that were done before by the agency and evaluate, just present some information in a report about, what a future state could look like. The other important thing to know is that the language in the proviso does describe that this report is due at the end of 2023, and there's kind of an acknowledgement in the language that the current contract that we have goes through the end of 2029. So that seems like a really far off concept to be sitting in 2029 or 2030. But when you really step back the timeline for, if we were to need to bring some of these resources in and renegotiate parts of the contract, it really is kind of timely to start talking about this now if this is something that is a reality that the legislature wants to pursue. So this report would then ultimately lead to conversations possibly in the next biennial budget about what resources the Healthcare Authority might be provided to bring in any of those services that the legislature thinks should be brought back into direct state management. So it does seem a little strange to be talking about 2029 or 2030 right now, but that is kind of how long some of the roads are when you're talking about major infrastructure building and these types of services that if they were to be brought back in. So I think it's just it's a timely exercise. We're almost to the point where we have 400,000 covered lives between the PEB and SEB programs within the Uniform Medical Plan. And so it's just a natural question, I think, for the legislature to want to understand if there are efficiencies that can be gained now that the number of lives that is served is so much greater than it was a decade ago.
All right. Thanks, Dave. That was the last of my update. Are there any questions? I will be back at the next board meeting to give an update on the final conference budget.
All right. Thank you, Tanya. Appreciate it. Next agenda item, eligibility and enrollment policy development. Emily Duchesne, regulatory analyst in SEBB, is going to introduce A proposed resolution to address school employees returning to work from active duty. Our materials are behind tab number 5. Emily, welcome.
Thank you, Chair McDermott. Good morning to you and good morning to members of the board. It's good to see you again. For the record, my name is Emily Duchesne. I am the regulatory analyst in the Policy, Rules, and Compliance section for the SEBB division, and today I have one proposed policy resolution to introduce. Next slide, please. This slide and the next 2 slides are included in the presentation, so you will have them available as you consider the policy we will discuss. Thank you. Next slide. Here's the proposed resolution being introduced. This resolution deals with school employees returning to work from active duty. Next slide. Proposed resolution SEB 2022-01, school employees returning to work from active duty. When a school employee who is called to active duty in the uniformed services under USERRA loses eligibility for the employer contribution towards SEB benefits, they regain eligibility for the employer contribution towards SEB benefits the day they return from active duty. Health plan coverage will begin the first day of the month in which they return from active duty. Currently, school employees maintain eligibility for the employer contribution towards SEB benefits when they work at least 630 hours. Under USERRA, we need to restore benefits as of the day the employee returns. So we are asking the board to treat those that are returning from USERRA the same as employees who have met the 630-hour requirement. In reading this resolution to you today, it has come to our attention that it is written specific to health plan benefits. In the following examples we provide, you will see that the policy resolution should have been written for all SEB benefits to start at the beginning of the month for an employee returning from active service. I'll present the examples to you. Oh, please go back. Thank you. I'll present the examples to you, keeping in mind that the language in the proposed resolution will change the next time you see it to say employer paid SEB benefits when we bring this back to you for action. Next slide, please. Proposed resolution SEB 2022-01, example number 1. Steve works at Roosevelt Middle School. He returned to his job on May 11th, 2022, after 6 months of active duty. When Steve went on active duty, he was eligible for the employer contribution towards SEB benefits. When our employer paid coverage is reinstated, employer paid coverages are reinstated May 1st. This example shows how the eligibility works with a school employee who returns from active duty during the same school year in which they have left, and they have already met the 630-hour requirement. The next example will show you how the eligibility works when the school employee returns in a different school year after a longer period of active duty. Next slide, please. Example number 2. Penny works at Olympia High School. She returns to her job on Monday, April 25th, after 18 months of active duty. When Penny went on active duty, she was eligible for the employer contribution towards SEB benefits. When her employer paid coverage is reinstated, employer paid coverages are reinstated April 1st. Even though Penny was on active duty for 18 months and she returned to work at Olympia High School in another school year, her employer paid benefits will still be reinstated upon her return under USERRA and will begin April 1st because USERRA requires coverage to begin the day she returns to work. Next slide, please. Our next steps are as follows. We will incorporate board feedback in the proposed policies. You must submit feedback by March 18th, 2022. We bring recommended policy proposal resolution to the board for action at the April 7th board meeting. Next slide, please. That's it. That's all I have for you. Are there any questions?
As we open up for questions, there's one more piece of kind of context I want to give the board, and more importantly, members of the public who might be really interested in this particular concept. We are bringing this resolution because there's a federal compliance piece that has to happen. USERRA is a federal law that requires benefits be reinstated the day that the person comes back from active duty. The reality is that our system we have 12 medical effective dates. We don't have 365 in our system. We have the first of the month. So in the examples that have come up, we'll just take example one, Steve, when he comes back May 11th. You know, our choices are May 1st or June 1st. It was brought to our attention that the way our system is set up, that the natural answer without this policy resolution would be June 1st, which would not be in technical compliance with federal law. But, and in these types of instances, the agency will usually, if it can, just make the administrative change because we're charged with keeping the programs in federal compliance. The challenge we have here and why we have to come back to the board is if we were to just try to implement this scenario on May 1st, we would be inadvertently or taking extra steps to expand eligibility for the first 10 days of the month. And the agency doesn't have that authority. The board has that authority to set and expand eligibility. But before everyone gets excited about other instances of being able to retro enroll earlier in the month, I want to caution people that, again, the reason for all of this is to ensure federal compliance. But this is limited to specifically USERRA, specifically because of the federal compliance piece. But we did need to bring this to the board because of the technical expansion on eligibility, which is the board's authority, even though we would never recommend that the board continue a policy that would violate federal law and suggest the dates in this particular example be June 1st. So we're this is one of those where we usually don't bring something to the board where you can say no. It would be very difficult to, or challenging, and we would not encourage the board to turn down this resolution because we would be left in a scenario where there isn't a way to comply with federal law. But we also wanted to bring to your attention that there is something that really falls within your eligibility authority. And I just wanted to lay that out clearly because I'm concerned that others, public members who may want to analogize to a retroactive eligibility date in the future, I wanted to draw specific attention that this is really to ensure compliance with federal law. And if there are other instances of that are brought to our attention, we'll certainly bring that to the board's attention in future resolutions. But that's why this is so narrowly written to address this specific situation to ensure both federal compliance and what is operationally possible today. Just wanted to draw a finer point for that. I see Pam has a question, and then I'll let the chair continue to call on people.
Ask my question now?
Yes, ma'am.
Yeah.
All right. So Dave, thank you for that explanation because I was going to have two questions and that was the first one. Emily, I'm wondering with your examples, does this also include somebody who returns from active duty that hasn't met their 630-hour threshold yet?
No, it does not, because the federal rule requires that if they were eligible for the benefits when they left, they would be reinstated upon return. But that only protects the benefits that they had when they left. So if they had not met the 630-hour requirement prior to going on active service, they would not get they wouldn't get benefits when they come back. And that's why in the examples, we tried to emphasize a little bit, that when they left, they were eligible.
Okay.
So I apologize if that wasn't clear enough, but yes, that's a good question. And thank you for asking it because they would not get the benefits that they didn't have when they left for active duty.
I'm just trying to think of a situation where it could be somebody teaches through October, goes on active duty for a couple months. We assume that especially a full-time teacher, they have benefits, but they haven't technically met their 630. We just assume you start teaching full-time, you've got your benefits.
Right.
So I'm just throwing out that there as that might be like the minute example that applies to maybe 5 or 10 people, but just want to make sure that everyone still would have their benefits.
No, that's a good question. And I think that's something that we can consider between now and the next board meeting, if there's that situation that maybe needs to be fine-tuned. But I do think that you're right. In most cases, the person will have already met the eligibility when they leave.
Yeah.
There's always that possibility for an exception though. So thank you for bringing that forward.
Great. Thank you.
Yeah, you're welcome.
Other questions or comments? All right. Thank you, Emily. Appreciate the time.
Thank you, Chair McDermott. Bye, everyone.
All right. Our next agenda item is a UMP Pharmacy Benefit Management Update. Jenny Switzer, a Senior Account Manager for MODA, will bring the board up to date on changes implemented by MODA for UMP that went into effect this past January. Jenny's materials are behind tab number 6. Welcome, Jenny.
Good morning, Chair McDermott and members of the board. As Mr. McDermott said, my name is Jenny Switzer and I'm a Senior Account Manager for UMP. Today, I'm going to give an overview of the UMP Pharmacy Benefit Management Contract implementation. So a little bit of background on the MODA contract. The Northwest Prescription Drug Consortium, known as the consortium, is jointly administered through the Washington Prescription Drug Program and the Oregon Prescription Drug Program. We joined together to increase our purchasing power in 2006. And per RCW 70-14060, UMP must use the consortium for our pharmacy benefit. The prior MODA Health contract to administer the consortium expired on December 31st of 21, and we ran a competitive procurement, and MODA was awarded that new contract. The new contract became effective January 1st of 22, and it's a 5-year contract with an option to extend that contract in 1-year increments up to 5 years. So a little bit of the overview of MODA's structure. MODA administers most of our UMP prescription drug benefits in-house at MODA. They do, however, subcontract with another pharmacy benefit manager to carry out some behind-the-scenes administrative functions of that contract. And as we move into the next slide, I'll go over that a little bit more in detail. So with the previous contract, MODA's subcontractor was MedImpact. The new contract includes Novitas as the subcontractor. So as you can see here, MODA administers the account support, member services, clinical services, reporting and analytics, and benefit design. That subcontractor, now Novitas, performs claim processing. They manage the pharmacy network, and they have an additional reporting portal, and they administer our rebates for UMP. So the benefits of Novitas over MedImpact, there's several, and I'll go over a few here. We have more clinical programs to support the health of our members, such as pharmacoadherence programs. Novitas offers Costco as a potential second mail order option, and we're considering that for benefit year 2023. We are currently working with Costco to administer the direct-to-consumer over-the-counter COVID test kits. And as we work through that, we will be tracking how well that goes for that implementation decision in 2023. And that would be in addition to the postal prescription services that we currently have and that members know well. With Novitas, we're given greater options for administrative budget flexibility, as they offer the option of paying on a per claim basis or a per member per month basis. With MedImpact, HCA was allowed up to 4 user accounts on their reporting platform. And with Novitas, we can have up to 30 accounts. This allows for more options for HCA staff to complete data analytics and custom reporting, which we didn't have as much availability with MedImpact. And with MedImpact, Walgreens was an out-of-network pharmacy. With Novitas, Walgreens has been added to our pharmacy network. So to address how this affects the member experience, a lot stayed the same. The benefit design, prior authorizations, customer service, complaints and appeals process, all stayed the same. We still have a large pharmacy network with about 53,000 network locations. Arden Health for specialty pharmacy remains part of the contract, as does, like I mentioned, postal prescription services for mail order pharmacy. So in what changed, members did receive new ID and VIN numbers, which are used by the pharmacies for claims processing. All UMP members received new ID cards with this updated information and communications on the need to use those new ID numbers beginning in 2022. Novitas uses Medispan for drug designation, and MedImpact used First Data Bank. This change in drug database resulted in some changes in generic and brand drug designations. Based upon January's data, this resulted in a slight improvement in costs for UMP members affected by drug designation changes. And then there were the network changes of CVS and Walgreens. So CVS left the network and Walgreens joined the network. And I'll go over that in more detail in the next couple of slides. So with the change to Novitas, CVS did leave the network and Walgreens joined. That represented a loss of 47 CVS locations, an addition of 133 Walgreens locations. The CVS column here shows the number of CVS pharmacies that left the network for those impacted counties. And the Walgreens column shows how many Walgreens were added in those counties due to the change with the contract. As you can see, this resulted in a net gain of pharmacies in each county affected, with a total increase of 86 network pharmacies. In the next slide, you can see net changes by zip code. The green areas on this map indicate zip codes that had a net increase in network pharmacies due to Walgreens joining our network. The red areas indicate zip codes that saw a net reduction in network pharmacies. And the gray areas with no colors were not affected by the change in the CVS and Walgreens network updates, as they didn't have CVS and don't have Walgreens in those zip codes. So we did provide a lot of communications in a variety of ways to members to try and ensure understanding of the changes to pharmacy ID numbers and other network pharmacy changes. Some of those communications included the pharmacy open enrollment brochure for all members, the What's Changing publication that is available to all subscribers, the SEB UMP open enrollment pre-recorded video, so that's available on demand to all members. Intercom and UMP newsletters went out to all SEB subscribers via email or mail per their preference. We did have the pre-recorded webinar as well that included changes to the pharmacy network. The Washington State Prescription Services welcome postcards and the quick start guides were available to members and subscribers, as were welcome letters. And there was a web alert on the regents.com website notifying members to use that new ID number in 2022. Additionally, we had a lot of different areas that we provided communications to members, but here's some that we wanted to highlight. Additional communications to members are provided in the COCs. HCA worked with MODA to develop customized letters to members impacted by the changes. Over 4,600 letters were provided to SEB members who filled prescriptions at pharmacies that left the network. And that letter included the 3 closest pharmacies to their home location or their home address. And over 47,000 letters were sent to SEB subscribers notifying them of the change in pharmacy ID numbers so that they would know to use those new ID cards that they were receiving in 2022. HCA and MODA developed a custom customer service recorded greeting that played for callers when they called MODA for customer support. The December recording informed callers that they would be receiving a new card in the mail and to use it when filling prescriptions in 22. And the recording in January notified callers that they should have received a new ID card in December and to use that when filling prescriptions. And HCA developed a custom Smart Health activity tile for UMP members, notifying them of the pharmacy changes. 181 SEB members participated in that activity. And to support all these communications, MODA did prepare their customer service teams to make sure that members were receiving accurate communications and were being responded to in a short amount of time. So they provided additional training to their staff. They hired or put in place 9 new positions on their customer service team to handle anticipated call volume. And they worked extra hours whenever necessary and over holidays as well to help members. So Of course, there's always some member impacts when we're implementing changes to benefits or new contracts. To date, there have been 0 appeals related to implementation activities. This is due to MODA very closely watching claims, processing and addressing issues as they appear. As I mentioned, they did put in place those new customer service positions, and those positions will continue post-implementation to support our members as well. So members had access to customer service when they needed it, and issues were addressed very quickly. There were some member concerns that MODA received that were due to some differences in concurrent drug utilization review edits, which caused some claims to deny for high dose when they had been previously approved. MODA handled those issues as they were received and manually processed those to ensure members had access to the drugs they needed. MODA entered overrides to allow claims to process and have updated the DUR edit to return a message to the pharmacy rather than the claim have a hard stop as a denial. Another noted issue was with compound claim partial rejections for non-formulary ingredients. When these partial rejections were received, MODA reviewed the previous claims data and entered overrides just like they did with the DUR edits. So if that ingredient was previously approved as part of the compound adjudication, they overrode that so that the member could receive their drugs. A small amount of pricing complaints have been received. Many of those pricing complaints are regular changes that take place or outside of HCA or MODA's control. And some of the price changes that were indicate are actually that have been notified of indicate a cost savings for members. And some of those, like we talked about, indicate a cost increase for members due to the change in the vendor that they use. Those price changes were a result of the drug source classifications and maximum allowable cost list changes and changes to network financial guarantees. So just those contracts that Novitas enters into with those pharmacies. So that does bring me to the end of my presentation. Does anybody have any questions for me?
Questions for Jenny from the board or comments?
As we look for questions, I just want to give one more piece of context. If we can go back to the previous slide. I just want to put a little finer point on that last bullet. So an example of something that we've heard is an individual might have gone out for a drug that they may have paid 40 or 50 cents for a 90-day supply, and now it's $2. And what really happened was, and we don't need to go back to the slide, but if board members went back to slide number 6, Jenny highlighted that there was a change in the drug designation database, and that's kind of the manifestation of that, of what happened was the drug designation database switched from the previous entity to the new entity, and some drugs went up and some went down. The net increase across the entire population was positive, but as this board knows, when you're dealing with a large population, any change has impacts in both directions. The net change was positive across the population, but there are some people who were paying, 40, 50 cents for a drug that are now paying $1 or $2 for a drug, and some people were paying $10 for a drug that are now paying $8 or $7 for a drug. So it's just some of those natural changes. So if you hear about member complaints or there are more board constituent complaints that come forward with concerns, that's really what this is tying back to. So just wanted to draw attention. Most of the changes that we're aware of are small dollar impacts. We know that for retirees who are on a fixed income, every dollar matters. In these pandemic days where there's lots of financial challenges, every dollar matters. Just wanted to draw attention to a little bit more of the specifics in tying slide 6 and slide 11 together.
And Dave, just for clarity, when you say there was a positive change, people normally think positive is more. It actually is that people were paying less.
Correct.
Yes, okay. Any questions or comments from the board? Jenny, appreciate your presentation. Thank you for your time.
Thank you.
Why don't we go ahead and take a 5-minute break? We have one presentation left before the call for public comment. So why don't we resume at 9:56? Item is the 2024 Uniform Dental Plan Benefits Design Introduction. Ellen Wolfhagen, Senior Account Manager in the IRB Division, is going to share some foundational information for our Uniform Dental Plan benefit design discussions that could lead to changes in 24. Her materials are behind tab number 7. Ellen, welcome.
Thank you, Chair McDermott, members of the board. Good morning. Today, I am going to talk about potential design changes that could be considered for the Uniform Dental Plan, or UDP. I'm going to talk about some timelines, review some options for changes, first as a general matter, and then getting into some specifics, and there'll be time for questions as well. Next slide, please. For the background, as you know, SEB fully leveraged PEB benefits, meaning that the design for dental benefits was exactly the same in SEB as it is for PEB. But there was a promise to revisit that after we had some utilization information, and now's the time to do that. There were no significant changes in benefits in PEB for about 20 years, so it's a good time to start looking at this. 78% of SEB members use UDP. That includes, of the around 327,000 active SEB members, 257,000 are participating in UDP. Next slide, please. So in terms of the timeline, today we're introducing the options. When we meet again in April, I'll bring forward some data on utilization and potential costs as a range. There will be some cost impacts, and we'll look at them in terms of small, medium, or large. And then in May, we hope to reach consensus on relative priorities. And the reason for that is if we don't have full funding, it will help OFM and the legislature decide how to move forward. Next slide, please. There are other elements that have to happen besides just board review, and these are the remaining pieces of that. In the summer and fall of 2022, HCA will introduce a decision package on the budget based on the priorities that are set in the May meeting. In September, we hope that the budget proposals are finalized by the governor and he'll issue his budget. In the spring of 2023, the biennial budget for 23-25 will be finalized, which means the earliest benefit introduction would be January 1, 2024, or if we don't make everything into the initial budget and need supplemental budget, it would be January 1, 2025 for benefit introduction. Next slide, please. So I'd like to just review the current UDP design. There is a deductible, $50 a person, up to $150 for a family. The UDP is a PPO plan, and Delta has 3 tiers of dental professionals. The preferred providers, which provide the best contract agreement with Delta and therefore the highest coverage amounts. They have premier dentists who are paid at a different level, which results in a higher cost to the plan and a higher cost to members. And then they have out-of-network dentists. So keep in mind that there are these 3 different tiers. For class 1 services, which are basically preventive services like x-rays and cleanings, there's 100% coverage. And again, just a reminder, dental plans work differently than medical plans in that when we talk about who pays what, it's the plan paying most of the cost and the difference is paid by the member. It's a little bit different than the maximum out of pocket in medical plans, which is what the member pays. When we talk about a maximum, annual maximum, or a maximum, we're talking about what the plan will pay. Class 2 fillings, 80% coverage. So the plan's paying 80%, the member pays 20%. Class 3, which includes crowns, bridges, etc., 50% coverage. TMJ, which we will go into in a little more detail later on, is covered at 70% and has a $500 lifetime maximum. And the annual plan maximum is $1,750. Next slide. So to understand how we fit in the general market, we looked at not only our plans, but Delta's book of business, which is non-PEB, non-SEB PPO plans. And we also looked at the Washington Education Association plan that was in place prior to SEB. So as you can see, pretty much across the board, Class 1 is paid at 100, but please note that under the WEA plan, it started at 70% because of the incentive program that they had, and I'll explain more about that in a little bit. Class 2 is generally 80% in the industry. Again, WEA had a slightly different approach to this. And it is important to note that they covered crowns as part of Class 2. Generally speaking, Class 3 is crowns, bridges, and implants. And those are covered at 30%, and bridges and implants were covered at 50% as well for WEA. Just to note, periodontal care is Class 2, as is oral surgery or root canal. Those might be other things that you're familiar with as well. Next slide, please. So the options that we would like to have you consider, and these are not in priority order, but we'd like you to consider providing an incentive for using preventive services, and the impact of that would be to reduce costs in Class 2 and Class 3 services. We'll go into more detail on this in a bit. We'd like to consider having composite materials for posterior teeth fillings included, making an adjustment to the plan maximum. Again, that's the amount that the plan pays, not the member. Taking away a deductible for children's benefits, so reducing the financial impact there. And then we're going to look at TMJ lifetime benefit. Next slide, please. So having a plan that provides an incentive for preventive services would increase the amount that the plan pays, the coverage amount, based on one visit to the dentist per year. And so this would be Class 2 and Class 3 that would have their increased amount. Remember, currently preventive services are covered at 100%. The way that this increment works, it can increase by a standard increment per year based on the prior year's usage, and it would go up to a maximum. Benefits could also decrease for non-use to an established floor amount. Next slide, please. Looking at the market, large employers are not currently using this, but interest in it is increasing, and the reason is there's a cost benefit to there's a cost impact to this benefit, and that's why it's not generally adopted in the large employer groups. The WEA plan, pre-SEB, Class 1 and 2, so again, preventive services as well as fillings, started at 70% plan coverage and increased by 10% per year up to 100% plan coverage. And again, there would be a decrease if somebody did not see a dentist at least once in the prior year. Next slide, please. For people who are more visual like me, here's an example of how that would work. The current benefit period coverage level, that's the floor that you start at. You use your benefits. The increase happens in the next year. You use your benefits again in that year. It goes up the following year. Next slide. I'd like to talk a little bit about amalgam and composite materials. So we're talking about materials for posterior teeth restoration. Amalgam restorations contain elemental mercury, and they are less commonly used, although they are still used. Composite materials provide good durability and resistance to fracture, and they are more aesthetically pleasing as they can be tinted to match current teeth. Currently, composite materials are considered elective, meaning that the member has, in UDP, meaning that the member has to pay the full difference between amalgam and composite costs. Next slide, please. So as I said, it's currently considered elective in UDP. There are fillings in class 2 that could be covered fully, such as stainless steel or prefabricated crowns, and covered fully means covered up to the extent of class 2, which is 80% coverage. For large employers, it's included, composite materials are included in smaller fully insured plans. They're not included in larger self-insured plans. And remember, UDP is a self-insured plan. Pre-SEB, the WEA offering covered posterior composite fillings at a base of 70% subject to the increase. And crowns and onlays are covered under WEA as class 2 instead of class 3. Next slide, please.
Ellen, before you go to the next topic, I just want to highlight something else with composite materials. This is one that I think it's important to highlight that this one was brought to HCA's attention, or came on our radar as that all-important and ever-present equity lens as we look at our benefit designs and thinking about the challenges that are faced by having base coverage at amalgam fillings, which may put someone in a position financially of feeling that they have to accept elemental mercury in a filling if that is something that's available to them. Again, as Ellen highlighted, it's not as commonly used as it was in the past, but it is still an option in some dental practices. There are some dental practices that will refuse to do amalgam fillings, and then if that's the location that a member is at, then the coverage that is provided by UDP is adjudicated as if it's an amalgam filling, and then the rest of the cost is borne by the member. So it really was brought to our attention as kind of a socioeconomic equity concern, as well as that difficult position if someone does feel that they may be in no position other than to accept a filling that includes elemental mercury. And so this one really quickly became an important part of the potential conversation. And I just wanted to highlight that piece because I think it's important to show examples of where the agency is identifying equity issues and trying to address them and bring things within the policy boards that the agency supports, the decisions that the agency makes. And it's a very important one to highlight this on. So
Thanks, Dave. Okay. The annual plan maximum, again, this is the amount that the plan pays to the maximum level. The current level is $1,750, and as noted on the slide, this has not changed since 2008. And if you're curious as to what that amount reflects currently, in 2008 dollars, $1,750 would be equivalent to $2,285 in 2022. Preventive services count towards the plan benefit. So count towards the plan maximum, even though there's no cost share. And the average preventive visits, usually 2 times a year, run between $300 and $325 for both visits. In the SEB population, slightly higher in the PEB population. Again, the deductible is $50, and again, making the comparison to $2008, that would be equivalent to $65 today. So we've kept the deductible level the same, but we've also kept the plan maximum the same. Next slide, please. Again, I pointed out earlier that the PPO plans that Delta offers have 3 tiers of professionals. There's the preferred level, there's the premier level, and there's the out-of-network level. And PPO is referred to here as the same as preferred. And again, the annual plan maximum is what the plan pays. For UDP, it's $1,750 regardless of network status. It is interesting to note that in the Delta Book of Business, again, this is non-PEB SEB, their PPO plans, 43% of these have a $2,000 maximum limit. The pre-SEB WEA plan had $2,000 as the max for preferred providers and $1,750 as the max when a member used premier providers or out-of-network providers. One of the ways of adjusting for the difference in cost is an adjustment in plan maximum, such as WEA did it, or having a differential in the plan coverage the way that UDP has it. Next slide, please. Another consideration is to look at deductibles and figure out if we want to adjust those. Again, the deductibles, the amount that's paid, that the member must pay before the plan kicks in fully. There is no deductible for preventive services under UDP, but there is a $50 individual deductible and a $150 max for a family. So obviously, if it's just a member and spouse, it would be $100. The industry standard is $50 for an individual, $150 for family, and also a waiver for preventive services. The WEA pre-SEB plan had no deductible at all. Next slide, please. So one of the ways that we would like to increase utilization for our youngest members is by reducing financial barriers to pediatric care. And one of the ways that we can do that is to waive the deductible for children's visits. This can encourage early preventive visits and applies to restorative care as needed, and helps to develop lifetime habits of good oral care with children. And we know that lifetime habits of good oral care lead to better overall health as well. So it's very important to do this. Next slide, please. I'd like to do a little bit of a deep dive into the difference in children's benefits between what WEA's plan had, which was a program called Healthy Start, and what UDP has. So UDP was children's coverage is the same as adults coverage. Healthy Start program covered children up to age 15. For UDP, there's a $50 deductible, as we discussed. The Healthy Start has no deductible for children. For UDP, there's 80% coverage for class 2 benefits. Remember, those are basic fillings. And under the WEA Healthy Start, it was 100% coverage. And the final difference is that the plan maximum applies, that's per person, $1,750. So that would apply for children's services as well. And under the Healthy Start program, there's no annual plan maximum. Next slide. So temporomandibular joint, TMJ benefits. Clinically, this is a situation, disorders that result in pain in the muscles associated with the joint, or arthritic problems, or an abnormal range of motion. This is the joint that's at the back of your mouth that controls your lower jaw. There are some surgical benefits. Those are covered medically. Those are not covered through dentistry. And next slide, please. This is how generally these plans deal with TMJ benefits. So again, it's non-surgical benefits. UDP covers 70% up to a $500 lifetime maximum. As you can see, there's quite a difference in the Delta Book of Business. 50% coverage up to $1,000 annual maximum, and that's an annual maximum with a $5,000 lifetime max. But Boeing and Alaska Airlines, both large employers, have no coverage at all for TMJ. The WEA plan had 50% up to $1,000 annual maximum with a $5,000 lifetime maximum. Next slide, please. So as you saw in the previous slide, UDP has a higher percentage coverage than most large employers. We cover it at 70%, most cover it at 50%. It covers, as I said, only non-surgical treatment. That's true across the board. And treatment usually consists of retainers or spacers or night guards. Next slide, please. So in terms of our next steps, at the April meeting, again, I will bring some data on utilization. We will talk about potential cost impacts for each of these options in terms of small, medium, and large, and I'll provide any additional information as requested. And that's it. I'm open for questions.
Ellen, as we open for questions and discussion, the one other thing I want to highlight that will be at the April meeting is some more specifics about kind of the proposals related to each of these options. We wanted to describe them at a 50,000-foot level, but there's obviously a lot of details. What percentages? How would those sliding scales work in an incentive benefit design? What would the proposal for reducing the children's deductible mean age-wise? Does that mean 13? Does that mean up to age 14, age 16? So there's a lot of those finer details, which are also envisioned to be part of the discussion and presentation in April. So just wanted to highlight that for folks, because there are a lot of details, but focusing 50,000 foot and getting deeper as we go into the next meeting.
Thank you,
Dave. Board members always have an opportunity to send in written comments as they review the slides and digest. Do we have any comments or questions from board? Seeing none, Ellen, thank you so much for your presentation. Really appreciate it.
Thank you for your time.
Yep. Next item is the call for public comment. Is there anyone on Zoom that would like to provide comments? I'm going to let the room manage this part of the meeting. So if they see hands, they can sort of call on those one at a time. So Dave, I'll turn that over to you.
Okay. So far, I don't see anyone, but I do know that a few people literally joined the meeting as you were calling for public comment. They may be interested. So we are at the public comment portion of the meeting. I anticipate that there might be a hand raised. So I just want to make sure that anybody who just joined is aware that we are just starting to have public comment if you are interested in providing comments.
And go ahead and use your reactions to put your hand up so we can call on you. I'm scrolling through. I'm not seeing any, Dave.
I'm not seeing any either. Okay then.
Okay. Well, our next meeting is going to be April 7th from 9 to 2 p.m. Dave, any final comments before we adjourn?
Yes, I'd like to give a preview of the next board meeting. This was a very short board meeting. We were able to get through things even faster than I anticipated. Again, not the norm, so just enjoy it while you can. But at the next board meeting, a couple of things that we know will be discussed is we will plan to have an executive session after the public part of the meeting, and as we'll begin to describe the proprietary confidential information at the beginning of our annual procurement process. So do anticipate that starting with the next meeting, we will likely have executive sessions towards the end or after the public meeting each time. We will ask for action on the slightly revised and then stakeholder USERA policy resolution and receive a rulemaking briefing about the rulemaking process the agency does. Ellen will be back with part 2 of the data utilization specific proposals, relative cost impact, so that we can further have a discussion about those different benefit design aspects that could be on the table for dental. And a final budget will be passed by the legislature by that point. And so if there's any more revelations or information to share, we'll make sure to bring that back. So I will note that as a reminder, we put for the record filing purposes that the meeting would be from 9 to 2 o'clock. Obviously today we didn't go until 2 o'clock. It's easier for us to roll back the time than it is to expand the time. I'm not anticipating that it will go late into the afternoon in April either. I do anticipate it'll be longer than 10:30, especially with the executive session on top. So I anticipate board members to know that this really is the anomaly for duration of the meeting.
All right, well, I looked one more time through the list to see if there was a hand. There was not. So with that conclusion, I'd like to thank all the presenters today, the board members for attending, and the public for attending. We do appreciate your participation, and I am kind of looking forward to our first in-person meeting. Don't know when that is going to be, but we will figure that out as time goes on. So thank you all very much. This meeting is adjourned.